So for the second abstract, the number 2426, the management of outcomes of patients diagnosed with CML in blast phase, a multicenter analysis by the CML consortium. So the background is, despite multiple TKIs and newer treatment for AML or the ALL, outcomes of patients with CML blast phase or BP remains poor. The consensus guideline on the management of CML-BP are lacking. A recent study from the ELN reported outcomes of 240 CML-BP patients, and they reported marked heterogeneity in treatment patterns and no accepted standards. So our primary objective is to study the treatment patterns and outcomes of patients with CML-BP in the United States. So this is a multi-center retrospective study through the CML consortium. The key findings were that we analyzed the 72 patients with the CML-BP, with 50% were initially diagnosed with CML-CP or chronic phase, and 15% had accelerated phase or AP, and 35% of these patients are diagnosed with de novo CML-BP. The median time from CML-CP or AP progressed to BP was 26 months. Blasts were predominantly myeloid phenotype. About 50% of the patients had myeloid phenotype, and 40% of patients has lymphoid phenotype, and 3% of the patients has mixed phenotype. Of the patients with ABL kinase domain mutation tested, 43% had ABL kinase mutation, and most commonly the T315I mutations. The NGS showed that the most common mutations were ASX1, RUNX1, B-core, followed by others. And the treatment was heterogeneous. 80% of the patients received TKI plus chemotherapy. 13% received TKI alone, and 7% received chemo alone. Response rate was significantly better with the second and the third generation of TKI, about 77 to 80% compared to first generation TKI. The median OR survival was 18 months, with significantly improved outcomes for those receiving TKI combined with chemotherapy, which was 28 months, compared to TKI alone 13 months and chemotherapy alone 4.5 months. For those undergoing allogeneic stem cell transplant, the OR survival was not reached. Compared to patients who didn't receive allogeneic stem cell transplant, the OR survival was 14 months only. So we conclude that CML blast phase continues to have a dismal prognosis. Treatment is heterogeneous, involving various combination of TKI and chemotherapy. In our analysis, treatment with secondary or the third generation TKI led to better responses. In addition, treatment with chemotherapy in combination with TKI and allogeneic stem cell transplant led to the improved overall survival. Currently, the data from other institutions is being updated for further analysis and publication. Thank you.